here today at the National Rural Health Conference, and I have with me Professor David Tipene-Leach. Welcome. And I hear today you're going to be talking about something quite interesting, quite something at home, the wahakura.
Yeah, absolutely. So this Savo, I'm talking about the wahakura. We're talking about a Maori approach, if you like, to risk factors, about being a little bit courageous and working a little bit outside the square. So, you might recall that SIDS was the big problem, and once upon a time there were these 4 big risk factors which stuck out, and one was baby sleeping face down, next one was not breastfeeding, and then there was smoking, and then there was bed sharing. Yep, so those are the 4 big risk factors. We ran a program in this country in the early 90s that was called the National SIDS Prevention Program. Well, it didn't work in the Maori community. Predictably, it didn't work. In fact, we did predict that it wouldn't work because bed sharing, difficult to change, smoking, huge in the Maori community, and actually breastfeeding is actually another behaviour that's quite difficult to work with and change. So prone sleeping, pretty easy to change, certainly did change amongst Maori and non-Maori people, but the rates didn't really fall in the Maori community. They fell by about 5% in the Maori community over the next couple of years, and they fell by 64% in the non-Maori community. So it was a kind of classic example of a program that didn't work for Maori. Of course, it worked around the world, and it was a great piece of work, a great piece of research, a great piece of work, and it reduced SIDS around the world by 2/3 to 75% in a very short period of time. On the basis of it not working, we formed the Maori SIDS Prevention Program at Auckland University. We went around the country, we talked, we did the health promotion, we talked with women, we did all sorts of things. We tried to work with smoking, but we didn't work with bed sharing. We said, no, we're not going to spread the anti-bed sharing message. Anyhow, as it turned out, the rates in the Maori community began to fall. And indeed, they fell so that by 1995, they also had fallen by 50 to 60%. Great stuff. But what happened was that there was still this huge disparity of around about 5 times between the non-Maori rate, which kept on falling, and the Maori rate, which was also falling. So, nevertheless, I left the Maori SIDS Prevention Program at the time and went off to the coast, went into general practice, and kept on watching the numbers. What was happening to the Maori deaths this year, what was happening the next year, and after 4 years of no change, we began to think, gosh, we need to do something here, we need to do something different. What's the problem? And of course, we knew that the problem was, we've been saying it all along, was that the problem was that it was bed sharing if there was smoking in pregnancy. So we did a piece of work in Auckland in 2010 that kind of told us that 50% of Māori women smoke, 7% of non-Māori women smoke, and that 20% of non-Māori women bed share, and 64 to 70% of Māori women bed share. But if you put the two together, the differences between Māori and non-Māori is 1% and 21%, 21 times. So when you look at this thing, you're saying, well, okay, that's what we've got to do. We've got to do bed sharing if there was smoking in pregnancy. Not bed sharing. We weren't going to get down on bed sharing, but bed sharing if there was smoking in pregnancy. So anyhow, we came up with this crazy idea about wahakura. And the wahakura was based on kind of this thing that's become known as the wahakura lens. And the wahakura lens says, don't bother talking about smoking because it's too hard to do. Number 2, make sure that it appeals to Māori women. And number 3, actually there's a whole lot of evidence out there, let's get that together and use that as well. So the big piece of evidence that was around was separate sleeping surface, the power of the separate sleeping surface. And so we came up with, on the coast, the idea that we came up with was, why can't you have a separate sleeping surface in a shared bed?
Exactly.
That would keep the evidence online, the mums happy, and it would break this confounding risk factor that slotted together. So we started the program on the coast. on the east coast, up in Gisborne, and right up and down the coast. We moved it down to Hastings. We were grappling with 2 or 3 problems. Problem one was supply. You know, we made 100 of these things, and of course, no one wanted to give them back. They gave them to their cousins or their aunts or whoever, or the neighbour, whoever was having the next baby got the wahakura. So we had a supply problem, and we also had a credibility problem. So, you know, in a world that is saying the problem is bed sharing, not what we were saying, they were saying the problem is bed sharing, you've got to stop people from bed sharing. There was an incredible anti-bed sharing invective at that time. Of course, we were saying the opposite thing. We were saying, look, here's something to help us bed share. Well, that was a little bit outside the box, and so we had a credibility problem. Mm-hmm. So we went out around supply. We invented a different way to make the wahakura, and we made what's called a waikawa, which takes a couple of hours, don't have to prepare the flax so well, is equally robust, looks great, does the job, easy peasy. We had a colleague in Christchurch who we had this idea of the pepi pod. So the pepi pod was anything that did the job of a wahakura but wasn't made of flax. And we had this colleague, Stephanie Cohen, in Christchurch, who rang up one day and she said, I think we've found it. I think we found the pepi pod. It was a plastic box that was sold in the plastic box shop that was made for putting clothes under, your winter clothes under the bed in summer. Chuck away the lid, get rid of the wheels and the handles, and you had this wahakura-sized box. And so the pepi pod was born.
Simple and effective.
They were simple, they were effective, they worked. We still had to do a lot of work on safety because, again, it was a credibility problem and people didn't believe what was going on. So we did a random control trial on sleeping environments. We did the wahakura versus the bassinet, and then we did the pepi pod versus the bassinet. So, you know, we got that work done, we got it published, we followed the death rates, not so much the SUDI death rates, but the post-perinatal mortality death rates, because they were so immediate. SUDI takes 2 or 3 years to figure out. And we found that this fell, particularly for Maori, and particularly in the areas where there was lots of distribution of these things, by 29% over a 5-year period. So, you know, didn't eliminate poverty, didn't invent a new antibiotic or a new vaccination, didn't do anything. The only thing new was the Safe Sleep program. So the Safe Sleep program, which by that time had been taken up by 14 of the 20 DHBs, particularly the ones with high Māori population, and all done.
It's a great innovative idea, and the whole process is that you make your wahakura, you learn in the process, you take a responsibility while you're making it, you know, and in essence it's yours. You want to take it home and look after it in that way, and during that time you're learning about you know, maternal health and your health of your baby and all those kinds of things, and you can also pass it on to your family afterwards. It's kind of like almost like a hand-on situation. So you're not.
Can I employ you? That was fabulous. That's exactly what happens. You know, and young mums were doing that sort of thing, and they were just being taken up by it. The midwives were saying you put a wahakura in the middle of the room and people just gather around. They don't want to go home. Yeah. And, you know, you can sell them anything. You can even talk about giving up smoking.
Exactly, yeah. You can chuck a bit of health promotion in there. But also, one of the things I realised with it is that it enables people, like, kind of addresses the outside social things, like maternity bonds and things. You don't want to take your baby out of the bed if that means you're not going to bond with baby. So this is a great innovative way to keep that maternal pepi bond going on. Yeah, at the same time, you're saving lives effectively.
Well, absolutely, and that was in the early days when we knew that bed sharing was a risk factor. We didn't know in the very early days that it was bed sharing if there was smoking in pregnancy. The science at the time just said bed sharing. So that was a bit of a problem around the world, particularly in Indigenous communities. And as we've subsequently found out, in mainstream communities, 20% of people bed share. These are called habitual bed sharers. So these are Pākehā women who choose to bed share because it's good for them. Hello. It's not really a surprise when you think about it, is it? So there is this big bed sharing community out there, and the anti-bed sharing message was really quite big, and in retrospect was the wrong way to go. So, you know, here I am this afternoon talking about to a rural general health crew of docs and nurses and people who are out in the sticks, saying, well, here's me, I was in general practice and I had an interesting other thing that I was doing, and it turns out that actually it was really a good thing to do, and we've got a major turnaround in a major cause of death in this country. And who knows, it's going to be a world-leading program. Who knows?
Fantastic. I look forward to hearing your talk this afternoon. Thank you so much for coming along.
That's great. Thank you very much.